Okay. Can everyone see my screen okay?
Yeah.
Great. Okay, so why don't we start? So I'm just going to, I'm Dave Anthony. I'm going to introduce myself, and I'll have Sherilyn, who you've already met, and then Joe introduce themselves. So, and I'm going to be sort of the bus driver for this part of the breakout room. So I'm Dave Anthony. I'm the Family Medicine Clerkship Director at the Warren Alpert Medical School of Brown. And I've been the Senior Director of Aquifer for the past couple of years. And I'll just a quick reminder, people could mute their own computers just so we don't have background noise. Thanks. I've been the Clerkship Director of Brown for about 10 years and have been working with Aquifer pretty much since the birth of Aquifer Family Medicine. And I'm going to be talking a little bit about how I use it at Brown. Sherilyn, do you want to just, you've already introduced yourself, but again.
Sure. So I'm the Chief Academic Officer at Aquifer, and I'm going to be talking about how I use the summary statements in two different ways. So that's what I'm going to be focusing on, really in the clerkship, and now as my role as clinical skills learning specialist.
And Joe?
Hi, I'm Joe Wayne. I'm the Clerkship Director and Associate Program Director for Internal Medicine at Albany Medical College. I've been with Aquifer since the inception of the internal medicine cases, and have somehow moved my way up to assessment lead. And for my role in assessment is mainly with looking at right now the clinical decision-making exam, which is a different kind of test that I actually use in my clerkship for 5% of students' grades. We may increase that this year with the format changes we're making, but time will tell about that. And I will talk to you about the clinical decision-making exam.
Great. So the way we do these breakouts is to try to have each of the presenters have sort of a teaching pearl that's relevant to the topic overall. And so, Sherilyn and Joe already sort of introduced their ideas. So I'm going to be the first one to go, and I'm going to be talking about how at Brown I use this mantra of trying to make the cases relevant and not required. And I'll be talking about my use of the summative assessment tools with Aquifer, and then also how I use the student case use reports in meeting midway through the clerkship with students. And Joe, as you mentioned, is going to talk about using the clinical decision-making exam to come up with a way of triangulating your assessment of students and getting a more robust view of how they're performing. And then Sherilyn, again, is going to talk about using summative statements, or excuse me, the summary statements that are one of the case features that she just demonstrated as a tool in formative assessment. And so I'll just jump right in to how I use things at Brown. And I'm having a little trouble getting my slides to move. There we go. So I've been using the Aquifer cases really since I started being the clerkship director about 10 years ago. And over time, I've really come up with this way of using it that works for me, which is to focus on making the cases as relevant to the students' learning as possible, and not required. So my mantra is relevant, not required. And I don't actually have a problem with requiring them, although students sometimes don't like it when they're required. But what really is important is to make them relevant. And so what drives relevance is the obvious question. And so I'm going to talk about three things, but the first one, of course, is assessment. That for many students and for most of us, what's on the test. If it's on the test, it's going to be important to students. And so I have made the decision, and have now for about 10 years, to use the Aquifer Family Medicine exam as our end of clerkship summative exam. And just in case you don't know about these exams, so for several of the courses, including internal medicine, pediatrics, and family medicine, there is a end of clerkship exam that is very similar to an NBME shelf test. It's a 100-item single correct answer multiple choice question exam, and with validated items. We've been using this in place of the NBME exam. And what I like about using it, and the way I've used it with my students, is just to tell them, I know that every question that is on your final exam can be found somewhere within Aquifer Family Medicine, because the people who write and then work on validating the test questions take the content from the course to write those questions. And as the senior director, having going through all the exam questions, I know for a fact that every single question is found somewhere in a learning, in a teaching point in one of the cases. That doesn't mean it's okay. I'm back. Let me share my screen again. All right. Everyone back with me? You can hear me? You can see the screen? Okay. All right. So,
Yes.
So as I was talking about using the Aquifer exam, by assigning that at the end of the course, I know that students are going to have a reason to use. I can give a reason for them to actually use the cases, and we've done a study at Brown just in the past year where we've had the students take both the NBME exam right on the day right before the final Aquifer exam, and then take the Aquifer exam. And there's tremendous correlation between their performance on those two exams when they're taking them in the same, at the end of the clerkship, when they're sort of peakly prepared for taking an exam. So I also feel pretty comfortable telling you that preparing using the Aquifer cases helps students prepare for an NBME exam as well. So the other two ways I sort of drive their relevance is one is just with engaging with them in class. This isn't so much about assessment, but just for every didactic thing that we do in our family medicine clerkship, we assign a reading to do. And for each of those readings, it's always an Aquifer case. And we try to make our didactics engaging and use a variety of different engaged learning modalities, such as team-based learning or small group discussions or workshops. And so over the course of a whole rotation, actually a large number of the Aquifer cases we end up assigning as pre-work to come to class prepared. Now, of course, they're not required. Like I said, I don't require them, but it does help the class go forward, and it's efficient for the students if they come to class prepared, because they're both going to be able to engage in the discussion in class well, and then of course they're going to be studying for their exam. And then the last thing I use is a little bit of social pressure, and by that, I'm highlighting particularly using team-based learning. So a bunch of our didactic sessions are team-based learning, or TBL sessions, where the students are broken off into teams at the beginning of the rotation, and they stay with that team throughout the whole rotation. And as you might know from TBL, the very first thing you do is take a quiz on the content that you were supposed to prepare for in the class, and they take it as a team. And we don't formally grade them on those quizzes, and they don't grade one another on who came prepared or not, but they're aware in their team of who has done the reading and who hasn't. And just that little bit of social pressure, I think, helps the students feel like this is something they need to do. The other ways in which I make it relevant to them, one is just that I talk to the students, and I encourage you to tell your students about Aquifer and to show them the cases. So this is a still shot of my orientation slides, which is again a still shot of a case, which is kind of similar to what Sherilyn already showed you, where I'm showing not just how the cases work, but some of the features that she was showing you earlier, like the toolbar on the side, and just talk about how these are going to be used in their learning over the course of the rotation. And then, to me, the most important feature of using these over the course of a rotation is to actually talk to the students midway through. So there's this great course report you can get where you can see which cases students have done, and then you can pull up an individual student and see exactly what the student has read and what they haven't. And when I meet individually with the students midway through the rotation, which we do for every block, I pull the screen up and I show it to the student and I say, look, how's it going? And for years, I would talk to students about how their reading was going, and they'd say, I was a little bit further behind than I hoped I was, than I would be right now, but I think I'm catching up. And I would never know how far behind they really were and whether they were studying or at all. And now I have actual data. I can sit there and look at this with the student and say, you've really only read 2 cases halfway through. What's going on? And I've been able to actually help a number of students. Some of it's around study strategies, but actually more importantly, often finding students who are struggling for some outside reason just by having this conversation with the data in front of me. And that both helps me diagnose the learner and where they are as a learner, but then helps me coach them around learning strategies, and then helps sort of accentuate the importance of studying as they go through the course of the rotation. And so with that, and just the last point I'll make is just that with this process, we have been very successful. This is what the course report looks like at the end of one of my clerkships, which is that nearly every one of my students does nearly every case. So in the last year, our average case completion was 38 out of 40 cases. That's without requiring them. And I feel pretty good about students doing all that reading over the course of a rotation. All right. So moving on, I'm sorry we got delayed a little bit. We're a little bit behind schedule, but moving on to Joe.
Thanks, Dave. I can talk pretty fast. So I usually tell the students that they're no longer in school when they show up on the clerkship, that they're here to work. Don't think of me as their teacher, but think of me as their boss or coach. And that's because what we're really doing is assessing performance. Although we come up with a grade at the end, which I tell them I hate. I tell them this is the difference between taking a test and passing something, and demonstrating skills and passing something. So I always start with Miller's Pyramid. The Miller's Pyramid is just a framework for clinical assessment. He generally starts at the bottom with knowledge, and you can see the tools I use there to assess their knowledge. Then there's knowing how, which is what Miller described as the competent level. And for that, I have a bunch of things, and you can see the CDME starts to show up there. Shows how, which is their performance. So again, I have OSCEs, written HMPs, observed HMPs, and clinical eval, and then the does. So the CDME is kind of a knows how. It's really a test that's different than just a knowledge test like the NBME. It is a higher level test because it's actually trying to assess clinical reasoning more than just knowledge. They got to have the knowledge to pass, to do well on the test. But they also have to be able to reason through the scenarios presented. Next slide, Dave. So the clinical decision-making exam went through a rigorous development process. And there is actually an article in the literature that talks about the validation studies that were done. And it has moderate to high validation for being discriminatory as an examination. And it's a different kind of exam. It's not a multiple choice exam. There's no single best answer to the questions. Oftentimes there's multiple correct answers. The cases, the exam in internal medicine is based solely on all the internal medicine cases in Aquifer. And it truly does assess clinical reasoning. And I'll talk about a couple of things I've noticed when I get the results back and look at it to other student performance. And it's really, they're applying knowledge to the scenarios presented in the exam. And as I said, it has been validated in a validation study, which has been published in the literature. Next slide, Dave. So in the exam, which I forgot to mention is actually used as a licensing exam in Canada. And this is the format of the exam used. They do it over several days, so it's much longer than what we do. But there's 5 different types of questions that are on the exam. One is an undifferentiated complaint. So patient presents with abdominal pain. Patient presents with a headache. There are some with single identified problems. Patient has hypertension, and there's perhaps something going on besides that that's related to their hypertension. And could be a multi-system problem, a patient with heart failure and worsening renal function. Scenarios like that would be a multi-system problem. Life-threatening presentations, those could be things like acute coronary syndrome, brisk GI bleeding, sepsis, things of that nature. And they can be presented also as a regular preventive medicine type of scenario. A 47-year-old woman comes in for an annual physical exam, and then they usually will give you a little more information about them at that point, and then they'll work their way through the exam. Next question. The thing about the exam, there's no trick presentations. There's none of those like multiple choice questions where they word it funny to make you think the other way. These are pretty straightforward. You know, what would you do next? Kind of questions. And the questions are in different ways. Sometimes the questions will say, you can choose up to 5 of the following, and they'll have a list of about 20 to 30 options to choose from. Some may be, you know, in terms of giving patients verbal instructions. Some may be tests to order. Some may be therapeutic choices to do. So it depends somewhat on the question, but there's various answers included. And there are always multiple correct answers, but there are only a few key correct answers to the question the way the scenario was derived. And those are the correct answers that are scored. So, for example, they may say, choose up to 5 of the following tests. And there may be 6 or 7 out of the 20 choices that most people might order in that scenario, but none are really, but only 2 of them are critical to the diagnosis. So that's how they look at and weigh the questions. So, and one of the things they do that's unique too is that they also include some poison responses. What is a poison response? Poison response is when they choose to do something that could potentially be harmful for the patient. You know, sometimes maybe ordering a CT scan and exposing the patient to radiation or contrast dye with a GFR of less than 50 could be a harmful experience for the patient. And if they happen to choose that in their selections, and even if they choose all the right answers and the key answers, if they choose that CT scan with contrast, they will get 0 because they chose to do something that was harmful. And the reason they do these things is because when they say choose up to 5 or choose only 5, they're really trying to limit shotgunning where they can check off 10 or 15 answers. And sometimes in some of the forms of the question, it says choose only 5. If they choose 6, they may also get a 0 as well. So they really have to think carefully about what they want to do in terms of ordering for the patient when they're looking at these answers. You know, when I talk to students about feedback and I ask them about the exam, they give it positive feedback. In the end of clerkship eval, there have been, I've not seen any negative comments about the clinical decision-making exam.
Hi, John, this is Jeffrey Hogg. You had asked me to call.
Okay. All right. So then we'll, and then I'll let Cheryl then go.
Oh, great, thanks. And I'm going to put in a plug for the CDME. It is only for internal medicine. I took this as a pediatrician. And oh my God, it's so realistic. I felt like I was an intern again. So something about the decision-making process, only being able to choose things, it's very realistic. And I have been working with the University of Washington to consider using this test as part of our senior OSCE. I think it has great potential, but that's just like a work in progress for me. So I just want to end here with a few slides talking a little bit about the summary statement as formative assessment. And Dave showed you the screenshot of the report. So you can see the summary statements from all of your students. And the way that I've used this in the clerkship, so one of our assignments is for them to turn in H&Ps for review. So I do that, and I also do a subset of the student looking at their student responses for their summary statements. That serves 2 purposes. 1, they know that I'm looking and seeing what the quality of their work is. And 2, it allows me, just like Joe says, to triangulate a little bit of their skills. You know, sometimes the write-ups that I get are not quite so good. And it's like, is this just because the patient something about the patient or the encounter, or is this a real reflection of their skill? And so I don't want to wait until, you know, the very end of the clerkship to figure that out. So you can see here that you'll get student responses, and right next to the student response, you'll get an expert response. So I suggest only choosing 1 or 2 summary statements. You can imagine if you have a whole bunch of students and all of the cases, most of the cases have this, then it's just way too much work. So I would just do a spot check. Unless you have somebody who really has a problem. And then I think that this is a great way to begin to diagnose their clinical reasoning problems. And if you, Dave, if you can advance to the next slide, I'll show a rubric that we developed that's been published. And so the rubric is down there for you to find. And so we developed this rubric to actually gauge how students are doing as a piece of formative assessment based on the summary statements in Aquifer. And I think that this also can help you coach students. So I have used this to say, what's the next step? So if you have a student who's doing a great job, you always want to make them better. And so I have used this both for the students who struggle as well as all students to coach them. And you can see here the elements is, you know, so thinking about this as a standardized patient, I think that's why it's like a virtual standardized patient. You actually know what the content is. We've given you the expert content. Was it accurate? Did the student actually get the story right? And do the things, the elements that they include in their summary statement actually begin to narrow the differential diagnosis? It's a great conversation between what's the difference between a chief complaint and what's the difference between, you know, that summary statement at the end. And are they transforming key findings? So the examples here of, are you having a student, and everybody has a little bit different take on this about whether they actually want to hear the vital signs or it's okay to say tachycardia. But in the summary statement, you're really looking for that synthesis. And so you can see here that we weighted that. And are they doing a little bit, or are they still in that process of just giving you all the data and you figure it out? Are they using semantic qualifiers? So this comes back to sort of the illness script idea. You know, I think about acute onset of chest pain different than chronic chest pain, or acute onset abdominal pain different than chronic abdominal pain, or unilateral versus bilateral joint swelling. And so really coaching the students and helping them dissect where they can go next, it's a great tool. And whether you want to do the scoring or not, it's a little bit up to you. So you can fold that into your assessment. I find that the students really love sort of the overall coaching and moving forward. So I think that that's the last slide that I have. And so what we'd like to do is kind of open it up for questions in the time that we have remaining. I know that we have like 3 or 4 more minutes. So Kate, did you gather some questions that you'd like to start us off with?
Yes, there's a lot of interest in the eligibility for the CDME, and also in general, what makes you eligible to use the Aquifer Family Medicine exam, which Dave referred to. But I think it would be also helpful to talk about assessment in general. I think some of the folks on the call might not know about what's available in terms of our assessments and our move towards formative assessment.
Okay, great. Dave, do you want to take, or Dave or Joe, do you want to take any of that, or you want to turf it to me? We can do it anyway.
Sure. Well, I can take a little bit just about the family medicine exam and just who's the question about who's eligible. If I'm understanding correctly, if you subscribe to the course, that the exam is there for you to use. It's part of the subscription, and so anyone who's using it can use it. And as we've surveyed family medicine clerkship directors around the country, and know that while certain of us use it the way I do, where it's the end of clerkship summative assessment, other clerkships are actually using it partway through the rotation as a formative assessment tool, where the students take the exam and then get their grade back, and get a sense of how they're doing on the course of the rotation, and as sort of preparation for then using a different exam, probably a shelf test later on in the rotation. And I think I saw someone ask about the CDME exam. The internal medicine is the only course that has that exact exam. We have not developed that for family medicine or peds or radiology.
Yeah. And so Dave, thank you for that. Can you talk a little bit about maybe how the reports are structured for students? So if you use this as a formative, way, a formative test? What kind of feedback do the students get?
Yeah, so what you get both as a teacher, as a learner, you get, there's a teacher report and then an individual student report that comes back. It doesn't tell you which questions, what the correct answer was to number 3, because we're keeping the questions secure, but it does break down how you performed on, say, questions from case 6. So which is the diabetes case in family medicine. So you get a sense of how well you know the content from the diabetes case. It's a smallish sample, of course, because it's a 100-item exam. And so, there's only going to be about, 2 or 3 questions on average from each case, but it does give you a little bit of a sense.
Yeah, sure.
Great. And so somebody's unmuted, but just to let everybody know, we have a similar type of exam for pediatrics, use the same approach, and so as well as radiology. So those have multiple choice exams that give the same output as to help either as formative students to gauge their learning. In pediatrics at University of Washington, we use it as a final exam, just like Dave does. Joe, do you want to wax eloquent maybe about the process of developing the CDME? I can talk a little bit about that, why it's not available for peds and family medicine and stuff like that, but maybe a little insight about that.
I could wax, I don't know about eloquently, but it is it is a process. Developing each question is pretty much by committee. It's not a single person writing one multiple choice question. It's a team that works to develop the scenario, to make sure that the scenario is focused enough to lead the person down a particular pathway that they want to go. Sometimes the first question is, what's the diagnosis? And sometimes they can just type in an answer, or sometimes they have to pick from 3. And then after that, when they go on to the next question, which is they'll get a little more information about the scenario, again, which is devised to lead them the right way. And then they get the question to choose. And the problem of the test is, especially like that one, if they type in the wrong diagnosis, one of the things they cannot do is go back and change their diagnosis. So they'll see a question and they'll go, oh, and then they have to rethink where they were going with the question. And it takes a long time to develop one question, probably several weeks just to get one question developed. So from what I recall when they were doing it, so.
Yeah, it's a lot of work. And I think that, as we begin to probe and figure out, what do we want? What do you all want and need for assessment? And I think it's an opportunity. We did a little bit of trial once in pediatrics. We were totally jealous of internal medicine. We're like, oh my God, that is so cool. We want to do that too. And then we developed a group, and it is really hard. It is so hard to do. So I think that, as subscribers and users, you need to tell us. And if this is something that we need to invest in and would be useful for you all, then that's, part of what we could do in the future. Other questions I can see in the chat, about the self-assessment. You all can see that as well. The self-assessments really are for the students. I think that we are moving in the next couple of years to a different type of formative assessment that will have student reports as well as teacher reports to give you an idea about sort of how the students are progressing in a way and you'll be able to do it twice during your clerkships. So that's on the road to roll out in 2022. We'll be doing some pilot testing a little bit later in 2021. So.
And someone had asked about remote proctoring, and there was a text answer, but just to make sure everyone sees it or knows, Aquifer has come up with a plan for doing remote proctoring of exams with a camera, and that's what we did with our last block of students. It went very well. It was not a problem at all. The students were at home taking the exam on their own, and that worked just fine.
Yeah, it worked well for us too.
Yep, and for us at University of Washington. So I think that it's well done. So thank you all for your engagement. We're all going back to the big room. I think I have to get my slides ready and see you there.